discuss the clinical anatomy, the colpotomy and the colporrhaphy. The posterior colpotomy is done to drain the pus from the pouch of Douglas. And then we have intrauterine contraceptive devices that are used to prevent implantation of the fertilized oocyte. This is the intrauterine device, COPT. Now, the uterus is a common site for fibroids. You can see the multiple fibroids studded inside the uterus. The perineal body is one of the chief supports of the pelvic organ. Damage to this leads to prolapse of the uterus and prolapse of other pelvic organs as well. Now, coming to the vagina, this is a fibromuscular canal over here forming the female copulatory organ, and this term vagina means a sheath. The vagina extends from the vulva to the uterus, and it is situated behind the bladder, as you can see, and the urethra, and in front of the rectum and the anal canal. Now, as you can see, in the erect posture, the vagina is directed upward and backward, whereas in the long axis of the uterus and cervix forms an angle of about 90 degree with the long axis of the vagina. Right? This is about 90 degree. The size and shape. The anterior wall of the vagina over here is about 8 centimeter long and the posterior wall about 10 centimeter long. You can see it is longer than the anterior wall. Now, the diameter of the vagina gradually increases from below upward. The upper end or the wall is roughly 5 centimeter, twice the size of the lower end. However, it is quite distendable and allows passage of the head of the fetus during delivery. Now, the lumen is circular at the upper end because of the protrusion of the cervix into it. Below the cervix, the anterior and the posterior walls are in contact with each other so that the lumen is a transverse slit in the middle part and H-shaped in the lower part. Right. In a virgin, the lower end of the vagina is partially closed by a thin annular fold of mucous membrane called the hymen, whereas in non-virgins, this hymen is represented by rounded elevations around the vaginal orifice called the caruncular hymenalis. However, in females who are athletes or who undergo some physical training, their mucous membrane, this hymen, can also be around the elevations. Now, coming to the fornices of the vagina, the interior of the upper end of the vagina or the vaginal vault is in form of a circular groove that surrounds the protruding cervix. This groove becomes progressively deeper from before backwards and arbitrarily divided into 4 parts called the vaginal fornices. The anterior fornix lies in front of the cervix. This is the anterior fornix, and this is the shallowest. This is the posterior fornix lying behind the cervix, and it is the deepest. On either sides, we have the 2 lateral fornices. Relations. The anterior wall, the upper half, is related to the base of the bladder, as you can see, whereas the lower half to the urethra. This is the urethra. The posterior wall, the upper 1/4 is separated from the rectum by the rectouterine pouch. Can you see? This is the posterior wall of the vagina. The middle 2/4 are separated from the rectum by loose connective tissue. You can see this loose connective tissue. Whereas the lower 1/4 is separated from the anal canal. This is the anal canal by the perineal body and the muscles attached to it. Now, the lateral wall. On either side, this is the vagina. On either sides, upper 1/3 is related to the transverse cervical ligament. The transverse cervical ligament. in which are embedded a network of the vaginal veins, as you can see over here, right, vaginal veins, and the ureter gets crossed by the uterine artery. Can you see the uterine artery over here? And this is the ureter. The middle one third is related to the pubococcygeus part of the levator ani. This is the levator ani, related to the middle one third of the vagina. The lower one third, okay, the lower one third pierces the perineal membrane. You can see this is the perineal membrane. The lower one third of the vagina is going to pierce the perineal membrane, forming a vaginal opening, and is related to the bulb of the vestibule, the bulbospongiosis, and the duct of the greater vestibular gland of Bartholin. The arterial supply. The vagina is a very vascular organ. The main artery supplying is the vaginal artery, okay, which is coming from the internal iliac artery. In addition, the upper part is supplied by the cervicovaginal branch of the uterine artery. This is the uterine artery. The lower part supplied by the middle rectal and the internal pudendal arteries. Branches of these arteries anastomose to form the anterior and posterior midline vessels called the vaginal azygous arteries. Venous drainage. You can see there is a rich venous supply into the internal iliac veins, through which the vaginal veins, which are accompanying the vaginal arteries. You can see the veins are accompanying the arteries. Lymphatic drainage. Lymphatics from the upper one third of the vagina drain into the external iliac nodes, from the middle one third into the internal iliac nodes, and from the lower one third into the medial group of the superficial inguinal nodes. Nerve supply. Lower one third of the vagina is pain sensitive and is supplied by the pudendal nerve through the inferior rectal and the posterior labial branches of the perineal nerves. The pudendal nerve over here is the perineal nerve, and this is your inferior rectal nerve here, right? Now, the upper two thirds of the vagina are pain insensitive and are supplied by the sympathetic L1, L2 and parasympathetic S2 to S4, right? The nerves are derived from the inferior hypogastric and the uterovaginal plexuses. The sympathetic nerves are vasoconstrictors and the parasympathetic are vasodilators. The fibers which accompany the vaginal arteries form the vaginal nerves. Now, very important is the ureter inside the female pelvis, right? The ureter lies anterior to the internal iliac artery. You can see this is the internal iliac over here. You can see the common iliac. This is the internal iliac and this is the external iliac. This ureter is lying anterior to it, right? Immediately behind the ovary, forming the posterior boundary of the ovarian fossa. You can see this is the ovarian fossa where the ovary is lodged. The ureter is behind it, and it is anterior to this is the external iliac, this is the internal iliac artery. It is lying anterior to it. It is descending down the ischial spine, as you can see, and it courses anteromedially towards the bladder, right? This is the bladder. It is coursing anteromedially to the bladder. In the anteromedial part, you can see the ureter is related to the uterine artery. It's okay. The cervix and the vaginal fornices. The ureter is lying in the endopelvic fascia, inferior medial part of the broad ligament. You can see this is the broad ligament over here, and this is the ureter coming. Inferior medial part of the broad ligament, and this is a place where it can be damaged. It is accompanied by, it is related to the uterine artery over here and the vaginal artery over here, okay? So it can be damaged over here. Right, in the broad ligament, the uterine artery is anterior superior to the ureter by 2.5 centimeter, you can see over here. Then it crosses the ureter to ascend along the lateral side of the uterus, right? The ureter runs forward slightly above the lateral fornix of the vagina and 2 centimeter lateral to the supravaginal part of the cervix, then turns medially towards the bladder and is opposed to the vagina. The left ureter is more close to the vagina as the uterus is slightly on the right side, it is dextro-rotated, and vagina is on the left side of the median plane. One has to be careful of the ureter, especially during ligation of the uterine artery, because you have seen it is intimately related to the uterine artery. The ureter exhibits peristaltic movements with longitudinal plexuses of blood vessels, and it is a pale glistening and is palpable as a firm cord. Now, the clinical examination, the vaginal examination on inspection at the introitus, after which it is the speculum examination is done to inspect the cervix and the vaginal vault and to take a vaginal swab. Vaginitis is common before puberty and after menopause because of the delicate epithelium. In adults, the resistant squamous epithelium prevents infection, and vaginitis is commonly caused by trichomonas, monial, and the gonococcal infections, causes leukocoria or white discharge. Palpation of the pelvic organs can be done by upper vaginal digital examination. Right, so we can palpate anteriorly the urethra, the bladder, and the pubic symphysis, posteriorly the pouch of Douglas and the rectum, laterally the ovary, the tubes, the lateral pelvic wall, thickened ligaments, the ureter, and superiorly the cervix. The bimanual examination helps in the assessment of the size and the position of the uterus, enlargement of the ovaries or the tubes, and the other pelvic masses. The vaginal lacerations, traumatic lacerations of vagina are common, which can be caused by forcible coitus, which is called rape, or during childbirth or during accidents, giving rise to massive bleeding. Right. So we also have types of pelvic organ prolapse. What is a prolapse? Prolapse of the anterior wall of the vagina, right? So the vagina, bladder, uterus, rectum, drags the bladder, cystocele, right? This is the bladder, this is the anterior wall of the vagina. So when it prolapses, it carries with it the bladder. Now this is called the cystocele, and the urethra along with it called the uretrocele. The posterior wall, right? The posterior wall drags the rectum along with it called the rectocele. Weakness of the supports of the uterus can give rise to different degrees of prolapse. Similarly, trauma to the anterior or the posterior wall of the vagina can cause vesicovaginal between the bladder and the vagina, urethrovaginal between the vagina and the urethra, and the rectovaginal between the rectum and the vagina fistulae. Now, neoplasm. Vagina can have some neoplasms or malignant growth and infection, but like infections, they are uncommon. However, the secondary involvement of vagina by cancer cervix is quite common. Now, episiotomy is an incision given at the posterolateral side of the vagina to increase the size of the outlet of the baby during delivery, right? So you can see this is the episiotomy given. The fetal head is bulging out, it's the vaginal opening, right? And the position of the episiotomy incision occurs at the second stage of labor, and some of the muscles, that is the superficial perineal pouch, are incised.